Septic shock. I will give a lecture on septic shock today. A case scenario. A 60-year-old diabetic male patient presented with a history of dysuria and fever. His vital signs on admission were as follows: pulse 120 per minute, BP 80 by 50 millimeter of mercury, and respiratory rate 28 per minute. He was disoriented and agitated. Sepsis, which is a host response to an infection, can have a varied presentation and carries a poor prognosis. Early identification and appropriate risk stratification will help in elderly resuscitation with a decrease in morbidity and mortality. Step 1. Take care of airway and breathing. Proper airway care and, if needed, assisted ventilation should be promptly initiated in all the patients with severe sepsis and shock. Step 2. Assess the severity of sepsis. After initial resuscitation, it is important to identify and assess the severity of the sepsis. Categorizing patients into sepsis, severe sepsis, and septic shock helps in triaging, prognostication, and choosing the appropriate therapy. Step 3. Maintain circulation. Definitions. SARS, SIRS. Two or more of the following: temperature more than 38 degrees centigrade or less than 36 degrees centigrade. Heart rate is 90 per minute. Respiratory rate 20 per minute or more. PaCO2 is less than 32 millimeter of mercury. WBC 12,000, more than 12,000 or less than 4,000. There you will find 10% bands. Sepsis, SIRS, RS plus infection. Severe sepsis, sepsis with sepsis-induced organ dysfunction or evidence of tissue hypoperfusion like elevated lactate. Sepsis-induced hypotension. Systolic blood pressure less than 90 millimeter of mercury or mean arterial pressure less than 70 millimeter of mercury or systolic blood pressure decrease is more than 40 millimeter of mercury. Septic shock, sepsis with hypotension, that is systolic less than 90 despite fluid resuscitation. Insert a wide bore peripheral line and give initial fluid challenge, that is 1000 milliliter of crystalloids, normal saline or ringer lactate to achieve minimum of 30 ml per kg of crystalloids over 30 or 60 minutes. with careful monitoring of vital signs. Albumin may be added to the initial resuscitation fluid in patients having or anticipated to have a low albumin value. Hydroxyethyl starches with a molecular weight more than 200 and degree of substitution more than 0.4 should be avoided as these may cause nephrotoxicity. Fluid resuscitation should be continued as long as the hemodynamics based on either dynamic delta pulse pressure or stroke volume variation or static variable, that is CVP, urine output continues to improve and serum lactate continues to decrease. Recent trial conducted in Africa in pediatric population with severe sepsis have shown fluid loading and may be detrimental in this population. Step 4 is send initial investigations. As the patient is being resuscitated, send blood for complete hemogram. Blood cultures, 2 sets, and other appropriate cultures depending on the clinical situation, urea, creatinine, electrolytes, liver function test, ECG, and chest X-ray. Blood lactate. Send the arterial blood for arterial blood gas and lactate analysis. Increased lactate is a feature of global hypoperfusion and needs urgent attention. Serial lactate measurement is useful in monitoring response to resuscitation. If lactate is not available, base deficit, that is metabolic acidosis, can be taken as a surrogate marker for lactic acidosis. Appropriate viral cultures and real-time PCR, polymerase chain reactions, more sensitive and specific, should be obtained but should not delay the prompt antiviral therapy. Step 5, start antimicrobial agent, appropriate broad-spectrum antibiotics as per hospital protocol should be started immediately, preferably within 1 hour of presentation. Appropriate cultures should be sent before starting antibiotics, but if these are delayed for logistic reasons beyond 45 minutes, antibiotics should be started. 1 or more agents active against likely bacterial or fungal or viral pathogens and with good penetration into the presumed source should be selected. Combination therapy with an extended spectrum, that is beta-lactam and an aminoglycoside or a fluoroquinolone, is recommended for Pseudomonas aeruginosa bacteria. Combination therapy may also be used for patients at high risk for multi-drug resistant bacteria like Acinetobacter and in neutropenic and immunocompromised patients. A combination of beta-lactam and a macrolide should be used in patients with pneumococcal bacteremia with septic shock. The duration of therapy is typically 7 to 10 days. Longer courses may be appropriate in patients who have a slow clinical response, undrainable foci of infection, some fungal or viral infection, or immunologic deficiencies including neutropenia. Antiviral therapy should be initiated as early as possible in patients with severe sepsis or septic shock of viral origin when available, such as for severe influenza infection. In patients at high risk like those with neutropenia and severe immunosuppression, empirical antifungal therapy should be started. Now I will stop here for today. Next time I will bring you the remaining part of my lecture. Thank you.